third edition versus the fourth edition, there's some differences in some of the material that's in there, but also even they add an extra chapter, I think, in the fourth edition. They divide up some of that material a little bit differently. I don't want you to get overly hung up on that. I'm going to focus on things that are what I think are more relevant. Still, it'd be good to read over all the material, but I'm sensitive to that when I'm making up the test questions and things, the differences between the third and fourth edition right now. So just keep that in mind. We're going to do this on Friday, but we'll just briefly go through some of the principles again of somatosensory testing. So as a physical therapist, it's very important to be good at this and do it correctly, because if you don't, you can get bad information. And it's amazing, a lot of physicians, a lot of other people don't do a very good job of sensory testing unless they're, I've seen even neurologists get pretty sloppy with sensory testing. So I think it's good to kind of really nail this down. And you want to have your system, you want to have a pattern you do that you're consistent with every patient, so that when you see deficits, it's easier to pick those up. These are the ideal conditions. If you're going to do sensory testing with somebody, you want to be careful about it. You want to ideally be in a quiet environment so the person's not distracted. You want to have them comfortable, warm, not shivering, those kind of things. Explain properly, demonstrate what you're going to do, make sure they're clear about how they're supposed to respond to each question. Apply it in a systematic fashion. I do the same order, the same test, the same way 99% of the time, so that when I see a disruption or something different than what I'm expecting, it's easier to pick that up. It's generally okay for sensory testing to always work distal to proximal. The reason I say that is just because it is more common, no matter what the sensory problem is, to potentially have more problems distal than proximal. Why would that be? Why would distal have more of a problem than proximal in a lot of cases? What's that? It's a longer distance, so some disorders, the farther that signal has to travel, there's a greater chance you'll lose the signal somewhere along the line. That's not true for all diagnoses and disorders if you have a very specific localized peripheral disorder, but a lot of problems even in stroke. So somebody with a stroke may have an area, half of their body, but it's oftentimes the more distal part of the body will have more trouble than the proximal, even though you wouldn't necessarily expect that, but that is somewhat common. So it's just, again, getting a pattern down. You're comparing left and right, or involved and uninvolved side, okay? So if they have an involved side, you're comparing both, okay? It's never a bad thing to start with the good side, okay? If you know that they have a good side and you want to make sure that they understand the test and know how to respond, start on that better side, then work to the involved side, okay? If you're applying a stimulus and they're kind of getting into this pattern of responding yes, yes, or if they feel something, kind of sometimes you want to pause and vary the timing of the stimulus, just so they don't get used to just saying it and anticipating the stimulus, and just sometimes even they're not trying to cheat or be dishonest, but you could be sitting there and doing like your cotton ball every 1 second or so and working your way up, and they just kind of get this pattern, yes, 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 and they just keep saying yes, even though that you might hit a spot that they don't feel it. It's just kind of a reflex. So sometimes it's okay to pause, make sure they're on track with you. So the types of things we can test. So there's different modalities of sensation we're going to test with somatosensory testing. Discriminative or fine touch is one of those, okay? Conscious proprioception is another area, and then pain and temperature. These two together are pretty much dorsal column / medial lemniscus, okay? And then the pain and temperature is going to be spinal thalamic or anterolateral system is what you're testing here, okay? So with discriminative touch, there's a couple things you can do that assess that modality, okay? One is touch localization, which we'll go through. This is where you touch them with a cotton ball or lightly with a Kleenex, or even your finger. Your finger's not the best, but touch them lightly with your finger. And then you ask them, where did I touch you? With their eyes closed. But you ask them, where did I touch you? And if they're not good at kind of coming up with the anatomical location, you can even tell them to open your eyes and point to where you just touched them, okay? So as long as they're pretty close, so most people should be able to localize where you touch them. if they have decent discriminative touch and the dorsal columns are intact, okay, and medial lemniscal system. Another thing that tests sort of this discriminative touch is this tactile thresholds, the Semmes-Weinstein monofilaments. I did not show you that, did I, when we did our testing? I'll break those out on Friday. These are these little monofilaments that you push onto the skin. They have a little, they're like a fishing line, and they have different thicknesses, and you push it into the skin, and it deflects that. And there's different thickness values that they have on the side of this, and you can determine what is the thinnest monofilament that they can tell when you press it against their skin or you deflect it, okay? And that's their threshold stimulus. And there's different regions of the body, on the palm of your hand versus the back of your hand, top of your feet versus the bottom of your feet. Usually you do this on hands and feet. You typically don't do it anywhere else because you're looking at how can they feel things in their environment, manipulate objects. But there's a little chart in this kit that tells you what normal ranges are for different parts, and if you can check if they're outside those normal ranges. There's actually a special one, a Semmes-Weinstein monofilament in the kit that's for the bottom of the feet, that it's got a red colored monofilament. That's the threshold stimulus. If you put that on their foot and it bends on their big toe or the bottom of their foot and they don't feel it, that means that they don't have enough sensation to have protective sensation. It means that they are at risk, like if they had a rock in their shoe, they wouldn't notice it enough, and they could have wounds develop and those kind of things. So sometimes in the clinic, if you see a lot of diabetic patients, if you just have that one monofilament in your box, because these are pretty expensive. This kit I'm going to show you is about a $500 kit, but you can just buy those one monofilament, that threshold for the bottom of the foot, do a quick screen. Hey, I notice your vibration is diminished in that foot. I know you have neuropathy. Let me just see if you've got protective sensation. If they don't, you just say, hey, are they wearing appropriate footwear? Do we need to get them orthotic? Do we need to send them to a podiatrist to make sure they've got good footwear? Those kind of things. 2-point discrimination, this is where you got this little thing. We'll show you, we've got these little wheels. They look like little throwing stars, but they have little gaps between, different, like millimeter gaps between it. And we'll show you how to do that and test where that threshold is. What's the distance between 2 points? So you're looking for that receptor field, how tight those receptor fields are that they can detect between 2 different points touching at the same exact time. And then things like gravesthesia, stereognosis, and double simultaneous stimulation are required discriminative touch to do it. But that information is sent to not the primary motor strip. From the primary motor strip, this information then is sent back to an area just behind the, primary sensory strip, just behind the primary sensory strip, where you integrate it and come up with a picture. Or gravesthesia is where you actually take on somebody's hand, you draw a letter or a number, and then they have to report back to you what letter or number that you drew without their eyes closed. That's gravesthesia, okay? So they're putting together, they're feeling discriminative touch well enough that they can trace that pattern on their hand, and then that goes to the primary motor strip, the pressure, the touch, the sensation, but then it goes right back to the just behind in the parietal association cortex right behind, and it says, oh, that's a B, or that's an A, that's a 3, and it puts that picture together. So that's gravesthesia. Same thing with stereognosis. You put an object in their hand, eyes closed, you let them feel it, and they can tell you what that object is. So it starts in this primary sensory strip to get the initial information, then has to go back to the somato or cortical sensory organization area in the parietal lobe for them to be able to put that picture together. Double simultaneous stimulation is where you touch the limbs on both sides at the same time with their eyes closed, and you ask them, you say, you're going to tell me left, right, or both. And you'll touch either arms or legs, and you'll either touch their left side, right side, or both at the same time. If somebody has damage, again, to this area, this cortical sensory organization area just behind the primary motor strip, they may be able to feel left and right individually when all they have to do is focus on that one stimulus, because the primary sensory strip's okay? But if their stroke or whatever damage is just behind that primary sensory strip in this cortical sensory organization area, if you touch their limbs at the same time, if it's a left-sided lesion, they're not going to be able to feel the right side because they have sensory inattention or unawareness. So when stimulus is applied at the exact same time, they'll have difficulty deciding if there's two stimuli hitting them at the same time, because even though they have sensation when you test it individually, if you hit them at the same time, they're dominated by the information coming in on the side that's intact still. So we'll go through how you do that in class. So conscious proprioception is another way we can test this dorsal column medial meniscal system. Joint movement, which way did I move your toe, you know? Or actually, joint movement would be during the actual movement. So you would actually say, I'm going to start moving your arm. Tell me which way I'm moving it. And you actually ask them the question, which way I'm moving it, while you're moving it. So that's more of a kinesthetic awareness. So joint movement. So they would say, yeah, as you're actually doing it, which way are you moving it? Up, down, okay? Joint position sense is actually you move it and stop it in the new position, then ask them. I almost never do the joint movement. It's just really hard to isolate, and it's sloppy, and usually they can feel it, because if you're moving somebody's limb and it's a big enough limb or big enough region, you're usually stretching some skin or moving their other parts of their body enough that they might be able to sense, even in my trunk or shoulder, if I'm moving an arm up, which way you're kind of moving my other part of my limb. So it's a hard one to do. You can do it in the fingers pretty well if you really isolate the finger and ask them to identify as you're moving it. But it's really the same receptors and the same part of your brain that will tell you about even when you stop moving it, which way did I bend it after you've already stopped. So I just do it's cleaner to do the joint position than the joint movement, okay? So that's where you wiggle the joint and you stop it and say, which position is it in now? Up, down, straight, and we'll cover all that again. Usually you're doing it to a toe or a finger. Sometimes you'll move to a wrist or an ankle, sometimes to an elbow or knee, but very rarely. So all those can be used to cover, well, and then lastly is vibration, okay? So vibration is the last one. A vibrating tuning fork stimulates the same proprioceptors that are sending the information up the dorsal column medial meniscal system. I like vibration because it's fairly clean to do. You can somewhat isolate and move proximal to distal, and you can grade it. You know, you can actually count in your head how long they feel the stimulus, or we have the tuning forks that actually have these little, did I show you the Rydal Seifert tuning fork at all? I don't think I covered that, but it's actually got these little things at the tip that have these little triangles that when they vibrate, they overlap each other, and then the overlapping changes, and that's how you can actually get a number reading of when their vibration sense went away. So you can actually write down they've got a 7, or a 6. So it's somewhat more measurable and a little more controlled. So, and you will actually pick up a lot more subtle changes in proprioception and these, conscious proprioception, discriminative touch with vibration than you will with this wiggle your finger kind of stuff. You have to be pretty darn numb and have almost no sensation to not know if somebody's wiggling your toe or finger. And it same reason. Usually that movement will be transmitted somewhere up the line. It's hard to, kind of delineate that out. The anterolateral system, pain and temperature. So sharp, dull, that would be our safety pin testing. And that's probably the most common. That's pretty good for kind of determining if they have the ability to sense that sharp prick sensation. Okay. Hot, cold, we'll also test that. I don't do a lot of hot, cold testing. If I do, it's touching with a tuning fork, not for the vibration part, but just to see if they can sense if that feels cool to the touch to them. That's a very crude way to assess temperature. But if they're complaining to me, I don't feel like I feel hot and cold very well, I might just say, I'll just place the tuning fork. Does that feel cold to you? No, not at all. Okay, well, maybe we should do a little more testing. And if we're concerned about, a lot of times the occupational therapists will do this because there's more concern about safety and cooking, and if are they going to grab a hot cup out of the microwave and not be able to sense it. So they actually have these little kits that have it's like a thermos mug, and it's got these little metal cylinders that go down into the top. It's got a special hole, and you actually are supposed to, there's actually specific degrees, and on the top of this little metal cylinder, it has a temperature readout. So you can actually, that's got a little gauge, like almost like a candy thermometer. And you're actually supposed to set the hot and cold at a very specific temperature and they're actually pretty close to each other, because you should be able to discriminate between something not too hot and not too cold within a certain range, you know. You don't want to have to have it really cold or really hot to discriminate the difference. So there's actually some ranges that you would actually set that water. It sticks down in some water. You heat up the water, you put some ice in there, and then you put the little thing in there as soon as it's at the temperature, then you touch it to the person. But you got to dry it off, because if they feel the wet, that'll make you feel cold because of the evaporation. So you dry these off, and then you place it specifically on. So you can be a little more sophisticated if you want to. Deep pain and pressure. So deep pain and pressure is that slow pain pathways, okay? You typically don't test deep pain and pressure unless you're trying to get a primitive type of response out of a patient, because the deep pain and pressure goes to those divergent pathways, right? Remember those slow pain pathways, like this, particularly the spinal reticular path, right? The spinal reticular tract. It goes to that reticular activating or reticular formation in the brainstem. Well, in the reticular formation is the reticular activating system, which is the thing that makes you awake and alert. And that projects some, some of that area in the reticular formation projects norepinephrine up into your, cerebrum, helps you stay vigilant and alert. So what you do, like if I've seen a physician, or they come in and they do like a sternal rub, you get with your knuckles on their sternum and you rub it like that if they're not, conscious. And you see if that wakes them up, because you're stimulating that reticular activating system. Or you take your fingers and you go up to supraorbital pressure just above the eye, right to the, there's like a little nerve, it runs right there. You can almost feel a little notch right here on your brow there, and you push right in that supraorbital spot there really, really hard, and it causes intense eye pain and like a headache. And they'll do that to see if they can stimulate, just to get the patient to open their eyes, roll around, do something. If you are non-responsive to deep pain, that means you've got major cerebrum involvement, and brainstem as it could even involve. So you've got damage, swelling, something that's impacting enough of your cerebrum and brainstem that even deep pain won't get you to, try to avoid it, get away from it, get more alert. Okay? So we won't, unless you want to, we can practice that Friday. Find your favorite partner to partner up with that you've been wanting to do that with. This is that Semmes-Weinstein monofilament here. This is the little monofilament right here. Be careful with these on Friday, because the really small ones, they'll get kinked. And once it's kinked, it's over. It's done. It doesn't even really work for you anymore. So this little top here, it flips down this way. So the little monofilament flips up into a little slit right there to protect it. So just be careful when you're flipping that. There's a couple that have been bent, but anyway, life happens. If I'm doing a quick screen of a patient who I'm not doing an extensive sensory test for, my most common things I'm going to do that I feel like I get the best information for the least amount of time and equipment and effort is vibration for dorsal columns and medial lemniscal system, and sharp dull for anterolateral system. Okay. Remember I said, like a lot of times you'll see a therapist come in, or a doctor, and they'll go down to the patient's legs, after a total knee or total hip, and they'll just touch the legs and say, does that feel the same on both sides? And they just rub up and down on the leg. And you say, yeah, okay, good. That's usually not the best test, because you're rubbing over multiple dermatomes, and this kind of light, crude touch is carried on both tracks, right? You've got touch sensation both on dorsal columns and medial lemniscal. It's also carried on both small myelinated fibers or unmyelinated small fibers in the pain and temperature pathway, but large fibers, the peripheral nerve fibers. And so it doesn't tell you anything about specific pathways or specific types of nerve fibers that might be impacted. If there's no other reason, like the patient doesn't have a history of diabetes or anything like that, then maybe that's okay for a quick screen. It's just say, hey, make sure that they're feeling this leg okay. They've never had a past history of problems with sensation. But if I were an older adult, I just like to see. I have a ton of patients who have undiagnosed peripheral neuropathy, who don't have diabetes, who don't have other things in their record that but then wow, their foot is really numb. When I put vibration on there, nobody's ever tested, and like, your vibration is like half of what it should be, and that really can impact your balance. And I would have never picked that up if I just rubbed on their leg or their arms and says, does that feel the same on both sides? So there's a time and place for that, but most of the time I try to, if the clinic doesn't have it, I buy my own. I bought all those tuning forks for like $1.60. I found they're not the best, but hey, you can put it in your pocket. If you lose one, you got another one. start distal, move proximal with these tests, apply systematically, and we talked about some specific locations that are common, that I commonly use, that happen to capture distal to proximal, but also happen to hit some dermatomes and peripheral nerve distributions. So even if I'm seeing a stroke patient, I would not expect to see necessarily a dermatonal or peripheral nerve distribution. Like a whole half their body might be numb. But I still use the same pattern because it gets distal to proximal, it gets medial and lateral. It just happens to hit also some dermatomes and myotomes. So this is a pattern I can use with any patient, no matter diagnosis, and feel pretty good that I'm going to get good regions of their body, and I might pick up that occasional radiculopathy that still they have. Oh yeah, I have that neck injury from a long time ago that made me numb. I'm down by my thumb, or that kind of stuff. So the areas, let me change this to yellow. And we'll review all this on Friday. So for the upper extremity, I'm going to touch the thumb. That's going to get me C6. But it's also going to get me if I go to the back part of the thumb, it's going to get me radial nerve too, or the very outside of the thumb. If I do more on the knuckle, the very outside edge, that's going to get me C6 and radial. Or if I come back to the web space or back part of the thumb, that's going to get me that C6, but also radial nerve distribution. So I've got the dermatonal distribution plus the peripheral nerve distribution there, okay? Then if I do the index finger or the middle finger, I'm going to get C7. But I'm also going to get then, this is the same thing here, this is median nerve, okay? So I'm going to get the median nerve distribution, but also C7, okay? And then if I do the pinky, right here, I'm going to get C8, and I'm also going to get ulnar nerve distribution. Okay, so I've gotten 3 dermatomes and 3 peripheral nerve distributions that are very commonly involved with neck patients, with carpal tunnel patients, with all those kind of things. So it's just something you can, pick up. Okay. If it's a dermatome problem, they've got a spinal nerve problem. It's something up in their spine or their neck area or something like that, if it's an upper body thing. If it's a peripheral nerve distribution, it's going to be somewhere after it's branched off from that spinal nerve into its more final distribution. So you're looking, do they have carpal tunnel? Do they have a radial tunnel syndrome or something like that? Or ulnar nerve problem. They've been sitting there with their pressure on their ulnar nerve or something like that. Maybe surgery. I've had patients come in for total knee, and in surgery their arm was laying a certain way, and then they got an ulnar nerve palsy, after the surgery. Okay, so those are the 3. Those are the upper body, and then I can hit the inside of the inside of the elbow, right here, is going to get me T1. It also might get me another. I'm not too worried about some of the peripheral nerve distributions up here. They don't get as involved typically as some of the hand stuff does. So this is going to give me T1, and then if I get up here, and then I can go to the outside of the elbow. It's just going to give me medial and lateral on the elbow. It's going to give me again more of this C6 distribution or a little overlap into C5. Okay. Then if I touch shoulder up here, I'm going to get C5, and I'm going to get axillary nerve distribution, peripheral nerve distribution up there on the shoulder. Okay. Typically just the front of the shoulder I touch here. So those are the points. So 1, 2, 3, 4, 5, 6. 6 points I typically do in the upper extremity. And then we do a similar thing in the lower extremity. So down the lower extremity, we'll start big toe. That's going to give me L4. Okay. And that's also going to give me, that's saphenous nerve distribution. It goes down that medial aspect and down to the actually, I take that back. It's saphenous stops just right at the heel here. It would be superficial perineal, which is an important nerve to know because superficial perineal. So see, superficial perineal catches this more lateral aspect of the big toe, or most of the big toe here. Okay. Deep perineal kind of gets that web space area in between the big toe and the fourth toe. So big toe is going to give me L4 and superficial perineal. But then I do usually like the middle toe, okay? So third toe will get me, middle toe will get me the superficial perineal as well, but also L5, and then the little toe. Okay, the little toe will give me S1, and it will give me superficial perineal as well. So that superficial perineal takes up most of that area. So you don't get a lot of different differentiation in the peripheral nerve distributions. You know, if you do that web space, you can get deep perineal. So, okay. And then I might come up to just the front of the thigh a little bit higher up and get L2 or L3, I should say. I'm not too worried about these L1, L2s. There is some overlap. There's overlap between dermatomes. So you have to understand these are not clean lines. So just be aware that these are not clean lines. These are blurred lines in real life, and you will overlap a couple dermatomes on most occasions during those transition areas. So you just do your best, okay? I mean, I will hit usually somewhere here, you know, I might go mid, lower limb, medial and lateral. Doesn't help me with any more of the dermatomes, and it helps me a little bit with some peripheral nerve distribution. Now I'm getting more some saphenous on the medial aspect over here, get a little saphenous nerve distribution for the peripheral nerve, but I'm just kind of moving a little more proximal. So if a person a lot of times peripheral neuropathy, their sensation starts to get bad just above their ankle. So then I'm going to catch how far above their ankle does they start to lose, you know, their sensation, okay? Or below the ankle, I should say, is bad. So I'm trying to find where's that spot where they start to have more return to normal sensation if it's more of a distal proximal thing. I might then hit medial lateral knee area. Again, just give me a nice little spot there. Again, not getting any differentiation in dermatomes here, but just, again, more proximal, distal, medial, lateral. Then hit that one spot, top of the thigh, just to get more of that L2, 3, 4 area. Any questions on, yeah?
It always has to be skin on skin.
Ideally, yeah, for any exam purpose, you got to, you know, but there's times you can't get access to that, so you do your best. As long as you're comparing side to side and they both have the same thickness of a jean or a, you know, pant or something like that on, you might have to push a little harder and take that into account. But ideally, yes, get skin on skin. There are electrodiagnostic studies that can be done. We typically don't do these electrodiagnostic studies. There are some therapists who get certified in doing some of these. So there isn't a certification process you can do. Most of these are done by physiatrists. So the physician will send them to a physiatrist as a physical medicine and rehab doctor who will do administer these tests. It's interesting. So there's a gentleman, Dr. Began, James Began, who he comes and lectures to you in neuro on spasticity management. So he does a lot of injections and spasticity management. But they actually do, and he does a lot of EMGs, so measuring the, you know, motor function of a nerve in EMG, electromyogram. In surgery, what they'll do is they'll have these little electrodes that they wrap around the nerve in the lumbar spine. If you're doing a back surgery, as they're working on your disc or they're working on, you know, doing some kind of a stenosis treatment or something like that, they'll have these little electrodes that wrap around those nerve roots to make sure that they're not impacting any of those. And so they're constantly sending a little blip of a signal. They send a signal into the nerve root to make sure it's still functioning properly as they're doing the surgery. And you can remotely monitor that. So they pay him to sit in front of a computer, not even at the hospital, and he remotely monitors that and then can call in if he sees a problem or something like that. So last time he was here doing a lecture, so on this screen over here, he had his surgery going on, and this one he's lecturing, and I'm like, I don't know how you do that. But he's monitoring the surgical thing while he's doing his lecture, and if he goes, if I have to, I just need to, you know, make a quick call, you know, if I see something that doesn't look normal. But he sees a little tracking of these signals going across, and if he sees something go wacky, then he's got to give him a call and let him know, hey, stop cutting. I'm like, okay, I didn't know that's how they did that. All right. So nerve conduction velocity studies are one way you can look at the integrity of your somatosensory nerves, or any nerve essentially, from one location to another. So in this case, this is somebody doing a nerve conduction velocity here. So you have a reading electrode and a stimulator here. And so in this case, the stimulator, they'll hit a button and it'll send a shock through the nerve. That shock will go, if you put a shock in the middle of a nerve, the shock will go both ways. The action potential actually will go both ways. So only when a normal nerve functioning always transmits it in one direction. It's coming from one location going another. But if you shock it in the middle of the nerve, this action potential will go both ways. So it'll actually send an action potential this way, and it'll send one that way, okay? So nerve conduction velocities, that's what you're measuring, is how fast. So it actually records. It knows when you did the shock, and this, you actually measure this distance between this spot and then this is the recording electrodes. This is on the abductor pollicis. You're hitting the median nerve here, and you're measuring how long it takes for that signal to travel, whatever, maybe 3 centimeters, across this gap, and that's across the carpal tunnel. And it knows that there's a certain meters per second that should travel in a normal median nerve, okay? And then it'll compare that to normative values for your age group. And if it's slow, that means you might have some demyelination or compression in that carpal tunnel area, okay? There's usually a second volley. So the first volley is this one, but there's a second volley. So this actually goes back up to your spinal cord, creates a reflex in the spinal cord, which that's a sensory signal. That's like tapping on your tendon, essentially, is what you're doing with this, but this is using electrical stimulus to do that. It'll reflex and send a signal back down here to move your muscle again, okay, because it's like a reflex. That's a second volley that you'll see, a second spike that you'll see in that. So that's test speed of nerve transmission in the periphery. So it's just looking at this peripheral speed of transmission, okay? That's just testing. But it tests both motor and sensory fibers. It's not specific to one, okay? You're stimulating both with that. You can assume, though, if these are all, your motor and sensory fibers are all in a nerve, right? They're all, you've got the nerve sheath, but then you have all the axons inside that, which can be both motor and sensory nerves. If you have damage to one, you probably have damage to the other. Another way of testing how well your nerves transmit information is a thing called somatosensory evoked potentials, or SEPs, okay? These test the integrity of entire sensory pathway. And what they do is they actually put, like if they're testing your sensory system, they'll put a little electrodes on your scalp right around that primary sensory strip, right? And they'll put the electrodes on there, and then they'll do something like this. They'll put the stimulus down here in your arm, and they'll stimulate it, and they'll see how long it takes for it to actually register up in your brain. And that takes into account both the peripheral and the central nervous system, because it's measuring as it goes up through the central nervous system. They will use this more with, say, somebody who say they have a suspicion of multiple sclerosis, where the damage isn't in the periphery, but it's in the central nervous system. So it can pick up a slowing down in the central nervous system if their peripherals is normal, because you're measuring the entire track or pathway, okay? Make sense? All right, so now we're going to talk about lesions affecting the sensory system, okay? So right now we're just focusing on sensory system. Some of these lesions will affect motor system as well, but we're just going to focus one at a time here. After we get through motor system, then you start putting it all together. So these lesions, how they affect motor, sensory, but let's just focus on sensory right now. So peripheral nerve lesions, so is something that could affect the sensory system. So these are anything that happens out in the periphery before they've come into the spinal cord. So you've damaged the peripheral nerve, the nerve root, the dorsal roots, the dorsal root, the rootlets. Anything before you get into the spinal cord is a peripheral nerve lesion or disorder, okay? Radiculopathies. A radiculopathy is a spinal nerve root problem. C5, C6, C7, L4, L5. That's a radiculopathy. That's damage to a spinal nerve that's bad enough to cause sensory problems, okay? If you're just barely like damaging the myelin, you know, that wraps around it, maybe your disc is rubbing on it, maybe you have an osteophyte in your foramina that's, you know, digging into a nerve there and irritating the myelin around that, then in causing some trauma to that nerve, then it might just cause some abnormal paresthesias, you know, where you're feeling this burning sensation or tingling sensation or shock-like sensation. The worse it gets, you go through different, and it talks about in your book, going through these different, like when your arm falls asleep, how you lose sensation, but then how you get it back. It goes through these different stages of sensory kind of paresthesias that you feel. You can kind of go through that process, but if your arm is really numb, like totally numb, then that means you've got some pretty good compression on that nerve or nerve root for radiculopathy. But a lot of times your patients will start out with that referred pain, like, ooh, my arm hurts down my, you know, when they say, oh, it no longer hurts and it's numb, that means it's generally worse at that point. You've actually got more compression on the nerve, blocking all sensation. They often feel better, like I'm glad it's not hurting anymore, but now it's totally numb. And usually at that point, your motor system's also impacted too. So, and they have weakness in that same dermatonal, now myotomal area. So that's radiculopathy. It's going to give you a dermatonal distribution, right? Associated with that spinal nerve, dermatonal loss. So that's what you want to write down for that is dermatonal loss. Diabetic neuropathy. Somebody who has diabetes, typically what happens is the farther and longer the nerve is, and the more distal it is, it's more vulnerable to damage. You've got the nerves get smaller, they have more fragile blood supply, smaller capillaries, and so what happens with diabetes is not only does the high glucose, you know, damage the nerve itself, but it damages the circulation near the nerve is what primarily leads to the nerve degeneration is the capillaries shut down, they get clogged, they get blocked, and you don't deliver enough oxygen to your more distal nerves in your feet and your hands. So those start to get impacted first with diabetic neuropathy. And then as they get worse and have diabetes longer, it gets more and more proximal. Even bigger nerves, more proximal nerves start to get affected, okay? And it is based on nerve length, basically. And so if you measure from my lumbar spine down to my big toe, that might be like 3 feet, you know, 3.5 feet down to that big toe. As my nerves die back or start to have problems, once I get to about my knees, if I take a look at from my neck to my tip of my fingers, then that distance from here is about the same as from here to here, and that's when they start to notice their fingers start to go numb. So the nerves of similar length, you know, that's when you start to see them start to go numb, is once you get just about to the knee level, then they start complaining about their fingers, and then it goes from there. And it works its way up over time and over years. So that's diabetic neuropathy. And that affects all the nerves, you know, distal and proximal. So it's not dermatonal in nature. It's a distal to proximal, like the whole limb. They call it the stocking and glove pattern. So it's like you're wearing socks that make you feel numb, or you're wearing a glove that makes you feel numb, because it involves all the nerves that are distal versus proximal. It has nothing to do with dermatomes, and it does nothing to do with specific peripheral nerve distribution. It's all peripheral nerves below a certain location, okay, or level. So that's diabetic neuropathy. Idiopathic neuropathy is this is the one I pick up on a lot of people that have never been diagnosed. So it's just an unknown degeneration of the peripheral nerves. And again, it's generally similar to diabetes. It's a distal to proximal phenomena. Starts distal, works proximal, has nothing to do with dermatonal levels or peripheral nerve distributions. It's the whole limb, distal to proximal. Excuse me. Next one is something like a carpal tunnel syndrome. What kind of a distribution is that going to cause? A carpal tunnel, what kind of a nerve distribution would that influence? What's that? So it'd be a peripheral nerve, and carpal tunnel would be specifically median nerve. So in the foot, you have like tarsal tunnel syndrome, you know, or you hit the superficial peroneal nerve and damage that. That's going to cause a very specific loss of sensory function in that peripheral nerve distribution. Okay, so that would be very specific peripheral nerve damage or distributions, you know. These are generally caused by some type of trauma or some kind of irritation to that specific nerve, compression, that kind of stuff. Shingles, okay, Brucella zoster, herpes zoster. Well, basically that's that virus. It gets into the nerve itself, and it actually works its way in the nerve sheath along a very specific, typically dermatonal pattern. Okay, so this is dermatonal in nature. So it actually works its way down a spinal nerve or distribution of a nerve in your face or head, or a lot of people have them in their trunk, and it goes right along the ribs in a certain dermatonal distribution. It works its way in that fashion. Let's go through spinal cord and we'll take a break here. Spinal cord lesions. So we just talked about peripheral. Now we're moving into the spinal cord. Okay, so now we're damaging the pathways, the tracks, in certain ways. If you have a complete transection of a spinal cord, so the whole entire spinal cord is literally, it's very rarely truly transected or cut. You know, you'd have to have a bullet injury or a knife injury that cuts through the whole spinal cord, or you'd have to have a fracture dislocation that stretches that spinal cord. Excuse me. But enough, you know, maybe I'll take a break right now so I can go drink a water or something. So yeah, let's go take a quick 7-minute break here. I'm done. All right. Spinal cord. Somatosensory problems when you have spinal cord damage. So transection of the spinal cord, so almost a complete, essentially complete loss of function below a certain level, okay? So if you have, you know, T2 or T1, whatever, but everything below that will typically have sensory problems. All modalities, if you have a complete transection, you've lost all modalities below that level of the lesion. You may have, let's say it's at T1, that's the actual injury is at T1. They may still have sensation down even into T2 and T3 because of that overlapping of dermatomes. So, you know, as you're testing it, you may notice that, hey, you know, I'm still getting some sensation down another level below. That's because of that overlaps in dermatomes and not those perfect dermatonal levels, okay? So that's what they mean by that. So transection, everything, because you've cut all pain and temperature and proprioceptive tracts if you've damaged the entire spinal cord. Nothing can get past that lesion to your conscious awareness, okay? Below the lesion, but everything above is typically okay. Okay, everything above the lesion is still doing all right, making it past. But that's very rare. Most times, you know, patients with spinal cords have somewhat of an incomplete injury, and still have maybe some sensory experience, or some tracts are still getting passed that go from certain, you know, based on that somatotopic arrangement and how symmetrical or asymmetrical that lesion of the spinal cord is. And when we get to spinal cord anatomy, we'll talk about very specific types of lesions: anterior cord lesions, posterior cord lesions, central cord lesions, hemicord lesions, which we'll talk about now. And we'll mention posterior here, but we're not going to get into all the other ones. There are other variations on this theme. So hemisection of a spinal cord, also known as Brown-Secord syndrome. Okay, Brown-Secord is a half of the spinal cord has been damaged. Okay, it's fairly rare to have just completely one half of the spinal cord damaged. Again, typically knife wound, gunshot wound. It can happen for other reasons, just depending on how things happen with the injury. Bone fragment can go in there and just damage half the spinal cord. If you have half your spinal cord damaged, you're going to have some very characteristic symptoms. Okay, you're going to have ipsilateral loss of proprioception. And when we say ipsilateral, if we're talking about an injury, we're talking about in relationship to the injury. So if the right side of the spinal cord is damaged, we're going to have ipsilateral or right-sided proprioceptive losses. Okay, and I'll draw this out for you so it'll make sense in a second. At the same time, you'll have contralateral loss of pain and temperature. So If it's a right-sided lesion, you'll have left-sided loss of pain and temperature. These are all below the level of the lesion, okay? So this is below the level of the lesion. You'll have ipsilateral paralysis. So you'll have paralysis on the same side as the lesion, okay? So, but we're not talking motor right now, but just know that you'll also have some motor problems when we get to motor system. If it's just purely a posterior column lesion, like you've just damaged those posterior columns, the fasciculus gracilis or cuneatus, you're just going to have loss of proprioception, discriminative touch. And if it's both of them on both sides, you're going to have loss of all proprioception, discriminative touch, conscious discriminative touch, some unconscious because some of the unconscious pathways are carried up there too, but you're not going to be aware of it. Below the level of the lesion, okay? Below the level of the lesion. So let's draw this out real quick here, okay? Let's see. Let's make my lesions, I don't know, let's make them in green. So complete transection. The lesion is blocking me in my cervical level here, whatever it might be, C6, okay? Sensory pathways, right? Nothing can get past that lesion, okay? So you've lost everything below the level of the lesion, okay? Below the level of the lesion, sensory-wise, right? No pain and temperature, no proprioception can get past from below the level of the lesion. Everything above, makes it past. Everything's good above that level. So from C5 and above, they have normal sensory function. That's a complete transection. Now let's do a hemisection. So we'll do this, or Brown-Secord syndrome. So just half of the spinal cord is damaged, okay? Let's do pain and temperature in red, okay? So let's draw pain and temperature pathways. You guys are looking at it this way. This thing's facing us, so that's left, and this is right, okay? So this thing's facing us, so this is left for you guys, and this is right. So pain and temperature coming in from anywhere below this level of the lesion. Remember, pain and temperature comes in, but what does it do immediately? Crosses. Goes up. So everything below the level of the lesion on the left side is okay. Okay. So this is a left-sided lesion. Left-sided pain and temperature is okay. But if we look at the other side coming in, all this pain and temperature coming in on this side crosses over and gets blocked, right? Blocked, blocked, blocked. So everything below the level of the lesion, pain and temperature, is going to be impacted contralateral to the lesion. The lesion is on the left. The loss of pain and temperature is on the right. So it's a contralateral loss of pain and temperature. And we mean contralateral compared to where the lesion is. So it's a left-sided lesion with right-sided loss of pain and temperature. But everything on this side makes it past the lesion. Everything above it's fine. Everything above this is fine. So if above the lesion, it's all good. And on the left side, pain and temperature is all good. Okay? So that's pain and temperature. Contralateral loss of pain and temperature to the lesion. Now if we let's do proprioception in blue. Proprioception comes in from the left side. It comes in, and what does it do immediately? goes straight up. It doesn't cross yet. So boom, it gets blocked. Boom, it's blocked. Boom, it's blocked. Boom, it's blocked from whatever level there. So here, proprioception is lost on the same side as the lesion. So you have an ipsilateral loss of proprioception. Ipsilateral, the loss of proprioception is on the same side. So left-sided lesion, left loss of proprioception. Everything on the right goes up. Oh, let me make it cross a little earlier. Everything on the right goes up fine, crosses over, goes here, you know, it's doing its thing. So everything here is fine on the opposite side of the lesion. They have normal proprioception, but they lost pain and temperature on that side because of where it crosses earlier on in the process. Okay? So that's a very unique kind of injury that and it's somebody, I had a patient who was inmate. I worked at a University of Missouri, Columbia, a hospital that had treated the inmates when they came in, and somebody had stabbed him with a shank, you know, right through his back. And he had this very characteristic Brown-Secord syndrome, and then you're paralyzed on the same side as the lesion, okay? So even though, like, here's a motor track coming down, motor track comes down, crosses over, and then goes down, but it gets blocked here at the lesion, so you lose motor control on the same side as the lesion. So if the lesion's on the left, you have loss of motor function. So this guy had, you know, paralysis. He was a thoracic spine. So he had paralysis in his left leg, you know, then he had the characteristic, you know, contralateral loss of pain and temperature, ipsilateral loss of proprioception, and when we get him up to stand at the parallel bars, he had a guard with him. I think he was a murderer of some type, but he had a guard with him 24 hours a day, and he was like 6'7", you know, massive dude. And they would actually put his handcuffs on the parallel bars. So we'd have to walk to the end of the parallel bars. He has handcuffs on. They'd take the handcuffs off, switch him to this side to turn around, handcuff him back to the parallel bars. It was a pain to do that. And so, but the guard was like, "You gotta watch this guy, man. He's pulling one on us, man. I know he's faking this." He thought he was faking this injury, and he goes, "I think he's just gonna try to bolt on us one day or do something." So this guy was like, I mean, he must have been a bad. I didn't know the exact history, but it's starting to scare me a little bit. So I said, I understand you probably history with this guy. He's probably faked some things, but unless he's been studying neuroanatomy books, you know, there's no way he's faking, you know, contralateral loss of pain and temperature and ipsilateral loss of proprioception, because that's what he has. So I'm like, I'm pretty sure his leg's paralyzed. He's not going to, like, all of a sudden start running here in front of us with that injury. So, but it was very kind of interesting times. So that's kind of how you can map that out from a Brown-Secord syndrome standpoint. Brainstem lesions. So now we're moving from the spinal cord up into the brainstem. And again, we're just focusing on primarily sensation right now. Brainstem lesions, you know you've got a brainstem lesion if you have one side of the face has loss of sensation and the opposite side of the body has loss of sensation at the same time, okay? Because in the brainstem, we'll show you a picture here, there's a part with the trigeminal nerve coming in where you can damage the entrance point of the trigeminal nerve, but also impact the other pathways from the body that have already crossed over at that point, so you get this ipsilateral loss of pain and temperature primarily, sometimes proprioception in the face, but contralateral loss in the body. So if you have a patient who comes in and says, you know, my face is numb, and my right face is numb, my left body is numb or has problems, you're going automatically, you're thinking lesion in brainstem, because that's the only place that you can create a lesion that will cause that, you know, deficit of problems with the same one side of the face but the opposite side of the body, or vice versa. Okay, so if it's in the brainstem and the lesion's on the right, the loss of sensation in the face will be on the right, ipsilateral to it. And the loss of sensation in the body will be contralateral, so it'll be on the left, okay? So let's kind of And there's a very specific lesion that does this Wallenberg syndrome, lateral medullary and pons syndrome. But anyway, so let's talk about the trigeminal nerve. And let's do that in, I don't know, orange. So trigeminal nerve comes in, right? It synapses with several nuclei, okay? So synapses here, here, and another nuclei up here. But it's coming in, and some of the pathways descend initially. That's the pain and temperature pathways. Some kind of come straight in. That's going to be your, proprioceptive information, okay? So those come in. And if you have the other pathways coming from your body, so now let's do pain and temperature in, pain and temperature comes in, crosses over, goes up, okay? Proprioception comes in, okay? Proprioception, all right, let's go blue. Proprioception comes in, oops, goes up the same side, but crosses over in the low medulla and comes up this way, okay? So let's get our green lesion here. Try to be consistent here. So if I have a lesion that impacts this region of the brainstem, I may get actually loss of sensation in the face on the same side. So this is our left side. So left-sided loss of sensation from the face, but right-sided loss of sensation from the body because of that, okay? Because the trigeminal nerve does eventually cross over. So some of these, if they can get past that lesion, they cross over, or they come down here and cross over. But if you block it right here as it's coming in, before it has a chance to cross over, in a brainstem lesion, you're going to get ipsilateral, so the lesion is on the left, ipsilateral loss of facial sensation on the left side, same side, ipsilateral, and contralateral loss of body sensation. So that's what I want you to mainly take away from that. If you've got a patient who comes in who has multiple sclerosis or has a stroke, and they say, bam, my face isn't numb over here, but my leg's numb on this side, you automatically are thinking it's a brainstem lesion right there, okay? It's a great way to narrow things down. And when we start putting together like key things that, when you're trying to think about these questions where you're trying to localize a lesion, there are key things in a patient's history that you can narrow it right down and get close. At least you should be able to, through a history and a couple little simple tests, to say, is it spinal cord, brainstem, cerebrum? And then from there, you can try to narrow it down further, exactly where in the cerebrum, exactly where in the brainstem. But you should be able to kind of, based on characteristic deficits of motor and sensory function, well, you should be able to say, is it in the periphery, peripheral nerve, spinal cord, brainstem, cerebrum? That's always your first thing. Is like, what general region is this lesion in based on their symptoms? So this mixed pattern of face and body is a good way to say probably brainstem. And that's all I was going to show you here, was the same thing I just drew out with you, is that blocking those pathways. Cerebral lesions. So now we're moving from the brainstem up into the cerebrum for sensation, okay? Thalamic lesions. It's common to have strokes in your thalamus. That's a very deep structure, and these deep penetrating branches of these arteries that go to the thalamus are prone to hemorrhages, but they're also prone to blockages, okay? If you damage that whole VPL or VPM, or combined VPL, VPM, is where you can have everything's crossed over by that point, right? All those pathways, your trigeminal nerve, and all your body pathways are crossed over by the time they get to your thalamus. So if you've got thalamic damage, you can have a complete loss of the entire side of your body and face opposite to the lesion. So if it's a left thalamic lesion, you potentially could have your entire right side, face, body, everything has impaired sensation, contralateral to the lesion. Does that make sense? Because everything's already crossed over and everything's close to each other by that point. Once you get to the midbrain, that really high part of the midbrain, everything's really close to each other. And then so at the top of the midbrain, thalamus, internal capsule. All those pathways, sensory and motor, really close together. So even a fairly small lesion in those areas can wipe out a whole side of your body. That's why those are bad places to have strokes and things like that, is in those areas where all those pathways are compressed, running right together. And they're all crossed over at that point, so you're going to lose an entire side of a body, motor, sensory, but we're talking sensory right now. Occasionally, if you damage one of the small, like intralaminar nuclei in the thalamus or don't not wipe it out, it'll cause severe pain. It'll cause this misrepresentation of pain where you get some misfiring of your thalamus that thinks you have this, it's called thalamic pain syndrome. And again, this is one of these pain syndromes that doesn't work, like opiates don't work really well or anything like that. Most people get better from it. They have a stroke, they have pain in their entire half of their body on the opposite side, but then over time your body accommodates and adapts to that. So now if you have, now we're working up into the somatosensory cortex, that little strip right there, that postcentral gyrus is what we're talking about, right behind the central sulcus, that postcentral gyrus. If you have damage to that somatosensory cortex, you can have loss of discriminative, this contralateral, right? Everything's crossed over at that point. Contralateral loss of discriminative touch, conscious proprioception, two-point discrimination, and sometimes localization of touch and fast localized touch. So the localization of touch is like two-point discrimination. Well, exactly where am I touching you? Okay, like point exactly where. They might be able to feel generally where you're at, but they can't localize it very well. However, if it's just the somatosensory cortex that's damaged, slow aching pain is preserved, okay? Slow aching pain is preserved at a conscious level actually in the thalamus. Okay, so you actually, the thalamus is somewhat of a conscious structure, and also in the limbic system. Remember the spinal limbic tract is related to slow aching pain, that cingulate gyrus, the fornix, all that stuff. You have some conscious awareness of that in those areas of the brain. So you will have the ability to sense this slow aching pain is preserved, and vibration is preserved, believe it or not. So you can actually still feel vibration, even if that's just the somatosensory cortex is the only thing involved. Okay? If you have damage to the parietal association cortex, which is just behind the primary sensory cortex, then you can have problems with things like anosognosia. Anosognosia is sensory inattention or neglect. This is where that simultaneous two-point discrimination. When you touch both legs at the same time, they may neglect or ignore the one side in preference for the other side, even though they still have some sensation in that side. It's because they're unaware. They just lack awareness of that side. Okay, even though they still may have some sensation in that side, they just have this inattention or neglect. Okay, it's gonna be pretty profound. I mean, there'll be, I could test their hand, like, here's your hand. I'm testing this. Yes, I feel that. Then you see them going down the hallway and their hands hanging in the spokes of their wheelchair, dangling along, and they don't even notice that their hand is doing that. They have sensation, but they get unaware. They neglect that side. They have both usually some spatial neglect and even some visual problems to that side, but there's sensory neglect. It's not a sensory loss. It's a sensory neglect. They're just unaware of the stimuli that's coming in from that side as much. Other things that would call, if you have that problem with that posterior association cortex, astereognosis. So stereognosis is the ability to tell, like, what this object is in my hand. Astereognosis is lacking the ability to do that, so they can't tell what's in their hand. Even though I could test and say, hey, they've got good, discriminative touch, those kind of things, but if it's purely that parietal association cortices involved, and not the primary sensory strip or anywhere else, they can feel okay, but then they can't picture what that is in their hand. They can't formulate or put together those sensations to make it understandable and give it that three-dimensionality and to be able to say that's a specific object. That also, you'll find they have agraphia. This is that, where you write on their hand, and they'll have trouble figuring out what you wrote on their hand. Even though they can feel it, they won't be able to tell you what you wrote on their hand. Of course, their eyes are closed while they're doing this too. So just to highlight where these areas are again for you. So this is the primary sensory strip right here. There's an area, it's kind of right in this area here. That is more of your parietal association cortices. It's not a, it's loosely defined borders, but it's just back behind this primary sensory strip, kind of sitting in this region here, is that parietal association cortices. Okay. And remember, this parietal cortex is really good because it has borders with the occipital lobe, temporal lobe, and this frontal lobe, and this sensory area here, so that it takes in information from lots of different stimuli and organizes it and associates it and makes meaning out of it, okay, including somatosensory information. So it's kind of a unique phenomena, but there's certain branches of the artery, like of the middle cerebral artery comes out right, and we'll do yellow again. It comes out right here and has branches that go up to supply this whole lateral part of the cerebral cortex. And so if you just knock out like this branch here and you get a nice stroke right in that cortical sensory area, their sensation is fine. They're actual individual sensations, but they can't put together and do the stereognosis, the gravesthesia. They may be neglect or unaware of the sensory experiences that are happening, but they have decent sensation. Okay, talking about pain here. So pain is a huge, huge topic that we're just barely scratching the surface on. But I mean, there's some really awesome research coming out about pain and the experience of pain, and more about the psychology of pain, the mind-body experience of pain. And no matter what, you cannot separate the body from the mind on this. And actually, maybe I'll share, if I can find it again, I might show you. There's a good New York Times article that just came out also about the placebo conversation, and you go to a lot of courses now in the physical therapy world. They talk about how to talk to your patients about pain, and that can be more effective than ever putting your hands on them. They talk about the physiology of pain, the mind, and how it's influenced by pain. No matter what, if you have pain for any period of time longer than a few minutes, it's going to start changing your mind and the psychology of how you experience and deal with pain. And a lot of that's also based on how you're raised and predisposition genetics and all these different things. But there's very specific things you can do in your conversation with your patient to maximize the potential that you can get them to deal with their pain from a mind standpoint as well as the physical standpoint. And we're ideally positioned because we're the ones that spends the most time. So while I'm doing my hands-on treatment, I can be talking to them about how the mind influences pain and techniques, strategies they can use. And really, I recognize my first job I had was with a guy who was considered a guru. He was the guru of Southern California. Professional athletes all came to him. Everybody, affluent people, the dignitaries, the whatever, and they'd all come to see this guy. And he was the guru of treating people with pain and chronic pain in the area of Southern California. And he just was a wacky guy. I had a hard time. I'm a very logical kind of person, and he did all kinds of crazy, anything that was the latest stuff. But he had a whole library. He was very well read and he read all aspects of pain and spirituality and psychology and all this stuff. So he had a very diverse background, but he always did these just kind of crazy things that I'm more of like mechanical, logical, and put it in a box and then A to B. But pain isn't like that. But I realizing it was more about his conversations he had with his patients than anything he did with his hands. Because anything he did with his hands or any little weird technique he was doing that month, he was always changing up, worked. Because it was him and it was conversations. And now that I'm seeing and reading this material, I see he didn't even try to do it. Maybe he did. Maybe he read all this stuff, but he didn't tell me that was a secret. But he would plant these seeds. When a patient would come in, he would be very specific about their pain and says, I'm going to do this technique. You're going to feel sore for 72 hours, but then you're going to feel 50% better, in 4 days, and you're going to feel 90% better on this day. And he would give them very specific numbers, very specific time frames, and guess what? It worked on most of the people. And so there's a really good story at the New York Times called The Placebo Conversation. And placebo is okay because our minds help with that. But you want to be informed about it. You're not trying to pull a fast one on the patient. You're using your clinical tools, your hands-on tools, your psychological tools to help people deal with pain. So specific types of pain. So this is this is a little bit of a different order from what I previously had. I did have this. I just changed this last night, I think, is when I uploaded this. Is a little different order. So I apologize if you'd already printed these off, but the material, the content is the same. I just changed the order to match the chapter a little bit better. Pain should be from, not from injured joints. So when you get that immediate trauma, I know it's hard to cover that up. You guys can't, though. Both A delta and C fibers are affected, so you get fast pain and slow pain fibers are affected. C fibers are very sensitive also to muscular ischemia. So here, if you've got trauma to tissue, like the muscles down below this level, obviously blood supply has been restricted, and you get ischemia, C fibers are very sensitive to ischemia. So anytime you have restricted blood flow to a muscle, compartment syndrome, and those kind of things, you're going to get some very extreme pain pretty quickly. The inflammation, so your cells are destroyed in the area. They're ripped open, and they're releasing all these histamines and bradykinins and all this stuff that cause your chemoreceptors and free nerve endings to get more sensitized. So, you know, it's going to make you more inflamed and sensitized to pain immediately after that injured joint, muscle, etc. Referred pain. So referred pain is pain perceived as coming from a site different from the actual site of origin. So radiculopathies fit under this. So they might have a, you know, bulging disc in the neck that's causing pain in the thumb, but it has nothing to do with their thumb. But they may not even have any pain in the neck, but they feel the pain here. That's a referred pain. Some people like talk about trigger points that refer pain too. So certain people have trigger points that cause referral of pain into certain regions of the body. Referred pain from organs, you know. So kidney referred pain, heart refers pain down your left arm, those kind of things. So that's referred pain. Myofascial trigger points, visceral structures, I already mentioned all those. So this is just showing you that. So some of the sensory areas, like there's sensory receptors on your heart that are often coming in at the same spinal nerve root level as a dermatonal region of your body. And so that's why you might have this, if you have ischemia going on in the heart that's bringing back pain to that same area of the dorsal horn where you also have dermatonal information coming from a certain region of the body, they can get some mixed messages, and you can have some of that referred pain. And you guys are probably learning about this in medical diagnostics, or will or have, about common referred pain areas associated with organ issues. Chronic pain, or well, we should say chronic nociceptive pain. So chronic nociceptive pain is pain that's due to actual continued destruction, damage, stimulation of nocioceptors, okay? So there's pain that they continue to have pressure on their carpal tunnel. They continue to have something, a bulging disc that pushes on a nerve all the time, and it's unrelenting, okay? That's chronic nociceptive pain. There's continued tissue damage, continued irritation of the actual free nerve ending nocioceptors going on. So could be cancer, could be pressure tumors on the meninges, or pressure within your compartment syndrome or something like that, where there's continued damage or stimulation of nocioceptors. Okay, that's chronic nociceptive pain. Versus neuropathic pain, or even chronic neuropathic pain, is where you have pathologic neural activity that's independent of actual stimulation of nociceptive nerve endings. So here, the person who's got the radiculopathy and had long-term pain into their arm because their neck, you know, their bulging disc, the surgeon goes in, gets rid of the disc that's pushing on the nerve, person comes out of surgery, and they still have the same pain. You know, they remove the stimulation. There's something going on there. That pain is being maintained by a change in their nervous system that's not related to no longer the pressure of the disc on the nerve, okay? So that's just neuropathic pain. It's maintained by the nervous system, not by actually stimulation of free nerve endings and nocioceptors anymore. You've fundamentally changed the wiring of your nervous system that it keeps the pain signals going without any continued stimulation of free nerve endings. So here's different types of neuropathic pain. So peripheral, injury to a peripheral sensory nerve. So this is like, you know, when you're the nerve itself is being pushed on or smushed or whatever, and you're causing or ischemic. And you're not stimulating the free nerve endings. The nerve itself is being damaged, and that's a neuropathic pain, a peripheral neuropathic pain. And so you can start out with something as simple as a paresthesia. When you lean on your arm for just a short time, for not very long, and it's got a little tingly numbness. And it kind of tickles. That's more of a paresthesia, a painless abnormal sensation. It's not, you wouldn't consider it pain. It's more like an itch or tickle. It's not real painful. Paresthesia. A dysesthesia is an unpleasant abnormal sensation. So now it's like, all right, this is not, I don't like this. This is, kind of a weird sensation I'm feeling, but it's not, it's kind of unpleasant, okay? Could be considered painful. Allodynia is a weird peripheral nerve problem that is pain from a stimulus that should normally not be painful. So if you've got a hyperexcitable peripheral nerve and an inflamed peripheral nerve, brushing a sheet across my arm should not be painful. But somebody who has a peripheral nerve problem where they've got lots of inflammation or the myelin's being damaged or something like that, it can get sensitized. And so just even brushing a sheet or blowing on their arm can cause pain. That's a form of allodynia. It's pain associated with a stimulus that should not be painful. And this is common in peripheral nerve problems. And then they've got this other term, and this gets messy, some of these terms, so I'm not going to try to pick on some of the stuff in your exam, but another term that he calls secondary hyperalgia. This is excessive pain from a stimulus that should only be mildly painful. Allodynia is when you get pain from a stimulus that should not be painful at all, but secondary hyperalgia, I'm giving you a stimulus that should be a little uncomfortable, but they're going, and just, reacting, way too much to it and having extreme pain for something that should only cause mild pain. I think these are fairly related to each other. Central neuropathic pain. So this is where neurons in the CNS, so this is now the pathways, the tracks. We're primarily talking about the pain pathway here. Normally stimulated by periphery, by your peripheral nerves and stimulation of those free nerve endings, now become abnormally active, even though there's no stimulation coming in at all. Okay. Things like deafferentation and phantom limb pain are good representative or good examples of central neuropathic pain. So you have somebody who's got a gangrenous limb, and they've had pain in this limb. They've been trying to heal this wound for years, some months or years. They amputate the leg. And the patient still feels like they have that pain down where their foot. They don't have a foot anymore, but they still have pain because they've had pain for so long on that same pathway. It's that nerve complex and those, first order, second order, third order neurons. They have changed their relationship so much that you have, increased neurotransmitter, increased neuroreceptors, increased connections between these that they stimulate themselves. They're like turned on by themselves all the time. And so even taking away the limb doesn't change the pain. You've got this centrally maintained pain syndrome going on because it's been stimulated for so long. I think it's supposed to stay turned on all the time. Okay. Deafferentation. Some people get this really extreme pain syndrome, like people like in a motorcycle accident or something, where their limb gets pulled, or they get the hyper side bending of the cervical spine, depression of the scapula, and it avulses. Their actually brachial plexus and the posterior nerve roots of their brachial plexus get ripped out. Okay, and when you all of a sudden take away normal, so they no longer have any sensory information at all going into these ripped out dorsal nerve roots, but you've ripped them too, so there's like these exposed ends, and you've torn up some of the myelin right there at the end, so you get this extreme burning pain because of that. This deafferentation pain is this extreme burning pain, and you hope that those those nubs scar down, but even when they scar down, they oftentimes have pretty extreme pain for months, years after this deafferentation. And when you're no longer getting the normal complex of, we get the normal range of sensation. We get, vibration and proprioception and pain and temperature, all that going into our dorsal roots. If all of a sudden you rip them out and you have no sensation going in, your brain and your nervous system don't know what to do with that oftentimes. And so it takes this it kind of goes haywire on you, and oftentimes it defaults to pain. And now you're not getting the normal complex of range of sensory experiences coming in, and you've got these, torn ends. It just can cause this extreme burning type pain. Now they have this, I'll also talk about in your book this thing called pain matrix malfunction, okay? Um, there's different terms that are used to kind of classify this that you'll see out there. There's reflex sympathetic dystrophy is what we used to call it when I was in PT school, reflex sympathetic dystrophy. Now the term is complex regional pain syndrome. So CRPS is what's more commonly used as complex regional pain syndrome. Older terms were causalgia and Sudeck's atrophy. Some people, it's more common in the hand and shoulder, so it used to be called just shoulder-hand syndrome. And some people still refer to that for like people with stroke. They'll get this thing called shoulder-hand syndrome, but it's really a form of complex regional pain. They've got this complex pain in a regional area. Usually it's like, it starts in one location, like somebody sprains their ankle. Seems like a minor sprain, no problem, but for some reason, genetics, personality, social aspects, other things, their limb responds very abnormally to that minor injury, and they get this cascading, extreme pain that not only involves pain, but involves usually some sympathetic responses. They get changes in vascular tone, they get all swollen and red, they get changes in their sweat glands, so it gets really dry, and then they get this sympathetically maintained experience on top of the pain, and it's a vicious cycle. The more they use it, the worse it gets, but if you don't use it, that also makes it worse, and it's a very challenging thing for a physical therapist to help once it's kind of started. Most of the time it is some type of an initial trauma. It doesn't always have to be 100% of the time, but most of the time it's like a surgery, a sprained ankle, a broken hand, something like that, a stroke. So it's usually that's what triggers. And it's hard to predict. They don't have the exact factors, but there are some factors. It's more common in women, so there may be some hormonal things and those kind of things that influence how response to pain and that kind of stuff. So they don't, is it an overactivity of sympathetic nervous system? Some people's sympathetic nervous system may be genetically programmed that it's overactive and it maintains this, inflammatory, painful type of response more than other people. Typically what you want to do is you got to find a way to get them progressively using that limb again in a way that doesn't elicit a certain level of pain. So you're trying to not increase their pain, but get them to start moving it. And they do things like now with the mirror therapy and those kind of things. And they have these prism glasses you can wear. So what you do is you're trying to trick your brain and your nervous system into thinking it's okay. So they'll take a mirror and they'll put it between your two arms. Let's say you have shoulder-hand syndrome and you can't move this hand. It's very painful. So they'll have a mirror right here. Your left hand will be behind the mirror. Your right hand's here. And you look at your limb and you basically just do exercises with your right hand. You don't even move your left hand. And you look, and it looks like your left hand is moving without pain. And they'll actually have you go through, whatever, 100 different repetitions or activities. And by you visualizing that and seeing your left hand move without pain, it starts to change those connections so that your body says, oh, I can move without pain, that limb, even though it's a trick. Even though you know you're being tricked, your brain will still respond. Because vision is such a really primal experience that we default to vision a lot. So I will trust vision more than my own sensation a lot of times. Have you guys seen that trick where you do the fake hand, and where you you put your hand down here and you actually put a fake hand and you put a little, looks like a sleeve going out, and you're sitting there and it's a fake hand, and then what they do is as they're brushing that fake hand, they brush your real hand. And pretty soon you transfer your own sensation to that fake hand. Your brain will trick you, and all of a sudden, if you time it just right, you keep brushing the two together. When you start just brushing the fake hand, you'll feel the sensation not coming from here. It'll actually feel like it's coming from the fake hand. And then they'll pull out a hammer at the last second and whack the hand, and it freaks you out because you're expecting to feel pain because it can trick you. That. Well, I think I still have it in the closet somewhere. I have a fake hand like that. I'll have to see if I can dig that out. That'd be fun to do. And do that on Friday. All right. Let's get through this here real quick. Mechanisms for producing, there's different ways that can lead to some of this neuropathic, centrally maintained type pain. I put 4 or 5 because your version 3 of your book talks about 5, edition 3, 5 different mechanisms, but the latest edition only talks about 4. They got rid of the altered top-down modulation. I'll mention it, but I'll be sensitive to the exam that I don't nail you on stuff like that. So some of the reasons you could have this neuropathic pain we've been talking about is this thing called ectopic foci. This is demyelination of the actual axons. So the axons get this little demyelinated kind of area that is called an ectopic foci. It's a focus area of demyelination that can cause even altered gene activity within the neuron itself when you start damaging the nerve like that. And it often will cause excessive mechano and chemosensitive channels. You'll actually start to get these, because of the demyelination going on, you'll expose some more and make these more sensitive mechano and chemosensitive channels so they're more easily to be stimulated and respond to painful stimulus, okay? That's ectopic foci. Ephaptic transmission. Ephaptic transmission and ectopic foci often come together because what you're getting here is you've got axons that are near each other. They're getting rubbed on, mushed on, irritated. Myelin starts to degenerate. You get ectopic foci, then you get crosstalk between them. So the pain spreads because when you demyelinate neurons next to each other, they can kind of like, get crosstalk between them. Okay, so that's ephaptic transmission. Central sensitization. So this is where the actual central pathway gets sensitized. If you keep using a certain pathway over and over again and keep sending pain signals, it's going to get stronger. It's going to have more connections. It's going to distribute more neurotransmitter in the synaptic cleft. You're going to get more receptors that are going to bind that neurotransmitter. And that takes weeks to months to years to develop that. It's not going to go away overnight. If you all of a sudden stop the actual pain, you can still have this very centrally maintained pain, central sensitization, okay? You can also have true structural reorganization, okay? And that's also associated with the central sensitization. So this is where you actually get, you might even get some crazy things like A beta fibers. Some of your proprioceptive fibers will start to synapse with C fibers in the dorsal horn, So normal proprioceptive input becomes painful now. You get changes in the number of protein channels and also changes in the number of receptors in the postsynaptic membrane. So these are all structural changes that occur long term in the central nervous system with chronically maintained pain. Altered top-down modulation. So this is problems with the anti-nociceptive system, which we're going to talk about. We have an anti-nociceptive system that starts in, a lot of them in our brainstem, some in our cerebrum, that send axons down to our spinal cord at each level in the dorsal horn to produce natural opiates to downregulate pain if we feel like, hey, the initial threat is gone, let's start downregulating the pain, we're taking care of this. Some people doesn't work very well, Do they have problems with dopamine, serotonin? Do they have depression? Do they have different genetics? Some people's anti-nociceptive systems just don't work real well. People who are exercisers, who really exercise and challenge themselves and create discomfort a lot, tend to have higher pain thresholds because they tend to, first of all, they ramp up that anti-nociceptive system, but they also, pain to me is like, if I don't ride my bike till I almost throw up or something, it's not a good bike ride, but other people are like, what are you thinking, But your pain is somewhat relative, so it's not as threatening to somebody who's used to experiencing pain. It may not raise their sympathetic levels, their tonal sets, all that stuff. They may not perceive it as threatening if they've been used to kind of sensitizing themselves to that pain within reason is okay, that challenging your system and those kind of things. Chronic pain syndrome is this lack of direct relationship of pain to specific tissue damage, so it's this neuropathic type pain. Over time, people end up having things like decreased endorphin levels. So these are people that they get, these anti-nociceptive systems don't work as well because they're just not able to dump enough dopamine and endorphins at the level of the dorsal horn. They may send up, their circuitry may set up these reverberating circuits. Remember we showed those axons will sometimes grow back to their own cell bodies and self-stimulate? People with chronic pain syndromes tend to have more of that. So they might get changes in structure of organization where once you start the pain, it wants to keep going and it keeps stimulating itself. Um, depression, sleep disturbances. If you have pain, then you can't sleep, which then lowers serotonin and dopamine levels because you're not sleeping enough to reproduce those effectively. So it's this vicious cycle. Then if you're not moving, you're restricting movement. Now you get abnormal movements and you get incoordination, and normal movements are not smooth anymore. And so it's just, again, that pattern, that vicious cycle. Even though it involves your mind, it's not a psychological problem. It is a physiologic problem with the connections of your mind and genetic alterations and so forth, but people don't want to be told they have a psychological problem. That's where you're reading some of this material about how to talk to a patient about saying, hey, it's not in your head. I believe you're in pain, but when you have pain, it will change your mind, but it's not meaning you're faking your pain. It's not meaning that you're just thinking this up or, making it up. It will infect your mind, and you can use that to your advantage if you know the right ways to address that. We already talked about this, the pain matrix malfunction, which is really this complex regional pain syndrome. Fibromyalgia, pain matrix malfunction, there's several things that kind of fit under this. Fibromyalgia is one of those, but also is this complex regional pain syndrome, which we already talked about. And then even some types of migraines can fit under this complex pain matrix malfunction, primarily for the trigeminal-thalamocortical pathways. Okay, malfunction of those pathways can play a role in migraines. This is somebody with a complex regional pain syndrome here, CPSR, RS. So you can see the swelling, the redness, big changes in how their foot looks compared to the other side. So that's that sympathetic changes you're seeing in the tissue, skin, the blood vessels. We're going to leave this for we will just finish up with this anti-nociceptive systems on Friday. We'll just wrap that up. We'll still meet in the lab first and wrap this up and then move into that. Okay, so bonus quiz on Friday on anything we've talked about the last 2 days. So.